Hi, everyone, and thank you for joining Camp Breastie, day 3. Well, really 2.5 days. So I'm really excited and grateful and honored to be moderating this panel with such an amazing group of women who have a lot to offer and a lot of information to offer right now. This panel is called The Newest Normal. And I have to say, you know, something that sparked kind of the name of this panel is a post that, you know, was published by one of our Breasties, Dana Donofree of Anna Ono Intimates. She had posted, it was a week ago, maybe sooner than that, about just that phrase, the newest normal, and how us as, you know, breast cancer survivors, patients, thrivers feel about that phrase, the newest normal. You know, this is something that we have been as a community really sort of struggling with to, you know, ever since we were diagnosed. Our normal was never going to be the same as it was before. And so when we hear that now kind of, you know, after COVID hit, it can be triggering, and it certainly has a different sentiment and a feeling. And so, you know, for us, it's definitely a little bit of a different, you know, feeling. And so, you know, I guess it's just something that I want to say here, and reiterating Dana's sentiment that it's okay to feel exhausted. It's okay to be in pain every day. It's okay to be sad. you know, it's okay to not have nipples. You know, this is your new normal, and we have been experiencing that, you know, ever since we were told those words that, you know, we have breast cancer or we have a genetic mutation. And so I'm completely honored to be sitting here with these women to kind of field some of our questions around how to navigate this other normal now. And so I think we'll start off by just doing a quick round robin, an introduction. I'll have all these ladies introduce themselves and what they do. And just so you guys know, quick housekeeping, there will be time for questions at the end. So feel free to drop those in the chat box, and then we will get to those at the end of the session. And then for those of you who don't know me, and I sound like I'm starting a maid of honor speech at a wedding right now, that's always how that starts. But I'm Tiffany Dyba. A lot of you on here know me as C-Dream. That stands for Cancer Doesn't Rule Everything Around Me. And I was diagnosed when I was 35 in 2018 with stage 1 hormone positive invasive ductal carcinoma. I had a double mastectomy, 8 rounds of chemo, 5 weeks of radiation, and now I'm on tamoxifen for the long haul. So really, really excited to be here. But this is not about me. I want to shine the light on these ladies here. So Dr. Peled, if you want to start and take it away.
Sure, thanks, Tiffany. So I'm Ann Peled. I'm a dual-trained breast cancer and plastic surgeon. I practice in San Francisco and also run our breast cancer program at Sutter Health, California Pacific Medical Center. I also am a Breastie as well, so story pretty similar to Tiffany's. I was diagnosed myself at the end of 2017 at 37, stage 1 breast cancer, and went through lumpectomy, oncoplastic reconstruction, radiation. Now I'm on tamoxifen. So I have to say I feel very grateful personally to get to be a part of this community, and it's really transformed how I think about care. So thank you all so much for getting to be a part of this today.
Thank you.
Hi, everyone.
Dr. Comen?
So hi, everyone. I'm Alexia Gaffney. I am a breast medical oncologist at the Cancer Center. And I had the good fortune of hearing everybody talk beforehand on the panel. And I'm just really so humbled and honored to be a part of this and to help in any possible way that I can. You guys are absolutely amazing.
Thank you. Dr. Knopman?
I'm Jaime Nachman. I'm a fertility specialist, and I run the fertility preservation program at CCRM in New York. And we help women and couples who want to freeze their eggs or freeze embryos after a cancer diagnosis. I am really honored to be here today and be a part of this group, and have met some women in this group who are pretty amazing. So thanks for having me on.
Last but not least.
Hi, I'm Dr. Alexea Gaffney, very much a part of the Breasties community, and so many of you know me as simply Dr. Alexea. I'm a triple board certified infectious disease specialist. I'm also trained and boarded in internal medicine and pediatrics. I'm a mom, and I am a breast cancer survivor thriver. I was diagnosed with stage 3 invasive lobular carcinoma in April of 2018. I underwent bilateral mastectomy with reconstruction. I had chemotherapy. I underwent radiation therapy, and I am on hormone suppression with letrozole and Zoladex for the foreseeable future. I continue to lend my voice and story to the breast cancer community, especially for women of color, because we've not historically been well represented in breast cancer communities and in these platforms. And so I'm grateful to be here.
Thank you so much. So I guess my first question is, and it's something that actually selfishly I've had a big question about, but then I realize in the community it's something that's really confusing to us. And I think this question will be of no shock to you, but when we hear this word immunocompromised, right? You know, especially as it relates to COVID and staying safe and healthy, you know, something that I have always wondered, and, you know, others have as well, is technically, what does that word mean? Because for me, for example, I've been out of active treatment since December 2018. So technically, does that mean I'm still immunocompromised? Am I not anymore? And so I think that there's been a lot of chatter in the community around what does that mean still? Are we more at risk even if we've been out of active treatment for a while? So I'd love to, and I think Dr. Alexia both and Dr. Comen can probably shed some really great light on that. So please, I would love to hear.
Yeah, so there are many ways in which a person can be immunocompromised. And when you're speaking to immunocompromised status in relationship to cancer, it's very easy for us to comprehend that those that are in active cancer treatment are immunocompromised, because we are all well aware of terms like neutropenia and bone marrow suppression. But we tend to forget that things like radiation therapy can also suppress your bone marrow. So the ability for the body to generate white blood cells that help fight infection is just one level of an immunocompromised status. And something that I'm very present to as just a general practitioner and as an infectious disease doctor, when a patient has a cancer history and they have had chemotherapy in their lifetime, we bring it up for the duration of their medical care. It is something that we always take into consideration. And then when you think about how cancer treatment is managed, right, we're using immune therapy, right? We're modulating the immune system to help fight cancer. And that's a suggestion that the immune system is not identifying and getting rid of cancer cells. So there is, some level of dysfunction going on there. And that's a very layered conversation that I won't get into. But yes, those of us who are part of the cancer community are considered high risk when you're talking about a pandemic. With specificity to COVID 2019, we're still learning a lot about who is most impacted. So other conditions come up. So diabetes is an immunocompromised state because the impact of uncontrolled blood sugar suppresses the immune system. If you take steroids chronically for any reason, you're immunocompromised. People with autoimmune diseases are considered immunocompromised because there's immune dysfunction that's present. So you really have to just be mindful to seek the information and know and understand your risk. And unfortunately, because of our cancer diagnoses and or our cancer treatment, we kind of get lumped into that group. And so we can't select ourselves out of it now because we're not in treatment. Even with the COVID 2019 situation, I was asked to do hospital rounds, and my clinical boss was asked before I was asked because he had to give privileges for me to round in the hospital. And he said, my first response is, you have to remember that Lexi is immunocompromised and you have to protect her if you're going to ask her to do this. And he knows full well when my treatment ended and when I returned back to work. So we as healthcare providers, we kind of never let that go for our cancer patients.
Great. Did you have anything to add, Dr. Comen, to that?
Yeah, I think Dr. Alexia, can you guys hear me okay? The audio was not okay before. You can hear me now?
That's better
I think her points were excellent, and I also think it's really evolving for us in terms of what we understand about COVID-19. I will say that in general, we are not as a Sloan Kettering community saying that patients who are on tamoxifen alone are necessarily immunocompromised to the same degree as people who are getting active chemotherapy or bone marrow transplants. Those are the patients that we are very concerned about with respect to COVID. And while I think there's a lot of nuances, and Dr. Alexia, you're the expert in infectious disease, you can speak to this. I think there's a lot of nuances in terms of how chemotherapy can affect people in the long run. But to the best of my knowledge, patients who have completed chemotherapy, who are on hormonal therapy, for example, are not getting COVID-19 at a disproportionate rate. They're not suffering from COVID-19 disproportionately. In fact, I've had very few breast cancer patients be affected, even with, working in Manhattan, and they have all, recovered in the same way that you would expect commensurate to the general population. That is not true for patients who may be very sick already and on chemotherapy for that reason. But the patients that so far that we're seeing in the studies that are really concerning are the ones, again, bone marrow transplants, chemotherapy for lung cancer where it specifically affected that. The other point to make, you guys can hear me okay?
Absolutely. Yes. Perfect.
The one thing that I think we're also learning about, so what I really meant by that is I don't want people to be incredibly frightened that, yes, it's important to know that you've had chemotherapy, but it doesn't mean that you're the same as a woman who is potentially in the hospital getting a bone marrow transplant. That spectrum is very, 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 very different. And it is somewhat reassuring that the few patients that I've had who've had COVID have done well, are doing okay now. And I think, you know, we all have to have precautions and be careful. And certainly as a healthcare provider, I'm glad you've been safe.
Thank you. Yeah, I agree exactly what you're saying in terms of it being such a wide spectrum. And this COVID has surprised us. We've seen one of the biggest risk factors being overweight or obese and having like hypertension and prediabetes. And those aren't folks who might necessarily fall into that list. So the bottom line is we all have to be careful. We all have to take the social distancing seriously. And the reality is those of us who've experienced chemotherapy and radiation and even breast cancer surgery, like we've already been through social distancing and isolation. It just wasn't called that when we did it.
Right.
Tiffany, can I add something on the on the surgery side? I know we're going to talk about elective surgery, but I get asked about people now that we're kind of going and starting to do our elective surgeries again, like breast reconstruction revisions and prophylactic surgery. I get asked a lot about, does going through surgery make you immunocompromised? And thinking about COVID. And I think the reality is we know that your body needs to do everything it can to be, you know, taking care of yourself, healing. And so I think to some extent, while I don't think it's the same as being an active chemo, like everyone else was talking about, I do think, you know, depending on your extent of surgery, but thinking about something, let's say like a prophylactic mastectomy and reconstruction, I think those 3 to 4 initial weeks, you probably are immunocompromised as your body is working on healing. And so again, I completely agree with everything everyone else is saying, that we all need to take precautions. And I think you should still go ahead with those surgeries. I think we feel safe about them, but I do feel like everyone needs to take that healing time into account and be even more cautious in that time.
Yes,
and there's also, I was going to say, do you think that there's also a component of, you know, if somebody were to get sick, generating a cough after they've had major surgery might hurt, might be harder, they can't lie on their stomach. And so all of those things, you know, like a little bit more precaution in that instance, because you really don't, I mean, a lot of us are kind of becoming a little bit more lax, but if you are having surgery, it might be harder to do some of the things that the average person would do to, you know, increase their lung volume, lie on their stomach, all of that.
Totally agree.
Yeah, and that's a great segue actually into my next question about elective surgeries. You know, that's been also a big topic of conversation in the community is around, and even still as we're starting to, you know, lift and go into phase 1 and things of that nature. But what can people do right now, patients can, like, who are scheduling, whether it's exchange surgeries or, you know, double mastectomies, what are nuances or differences right now in how to prepare for these surgeries, both kind of post-op or pre-op and post-op in terms of, you know, for example, will their loved ones be allowed to be in the hospital with them? How can people prepare? Because it is probably a bit different right now.
Yeah, I'm happy to jump in on that one. So it is different right now, you know, and I think that everything's very geographic and regional, right? So I don't want to be speaking for New York and the Bay Area. Our numbers have been very low because of our extremely early shelter in place. And I'm very grateful for that we've been able to do breast cancer surgeries actually up the entire time. But we, starting mid-May, are now getting into the surgeries that have been being delayed, our reconstruction revisions, our prophylactic mastectomies, our surgeries for women with DCIS. And it's very different now. So I think you brought up a great point, which is the not having visitors. And that's a big deal. I think if you're staying overnight after you've just had surgery and not having a loved one with you, that is hard. It is hard going back to surgery when you don't have someone sitting there with. I mean, for those of you who've been through surgery, been there, taking care of people. I can't imagine having gone into my own surgery or my kids going into their surgery without someone there. And I think preparing for that it's a big deal. And considering, maybe some of my patients are asking if they can go home the same day rather than staying overnight because they'd rather be with their family. And so making sure that you ask your provider, ask your surgery center, hospital, what is that going to look like? We're testing all of our patients before surgery for COVID, and we know that people are at increased risk for complications and issues if they have asymptomatic COVID and have surgery. And so I feel much, much better on a personal level about offering these surgeries to patients now that we're testing everyone for COVID. And I think that helps a lot. It's a stressful process when you do it, but it makes a big difference. And then I think it's the same things that ideally for anyone who's having more elective, if you will, in terms of non-urgent surgery, get optimized. So I'm a big proponent of trying to exercise, this idea of prehab, get your body ready before you go into surgery. And I know it is hard with COVID and everything else going in the world right now to get up and exercise and take care of yourself. But I think as much as we can do that, I do feel like the people who are in the best place going into surgery are the people who do best on the other side.
Great. No, thank you. My next question is for Dr. Knopman, and this is around family planning during a pandemic. So is that safe? How do women protect themselves? Have you been suggesting? People that come see you, I'm sure in varying degrees are very much panicked about will they be able to go forward and have children and already with their diagnosis or genetic mutations, and then you throw COVID into that. And so is this safe right now? What would you suggest?
Yeah, so most IVF centers are open and doing fertility treatment, whether it be fertility preservation or treatment for women who are trying to conceive. There was about a 3-week period where we were not doing IVF or fertility treatment, but we're still doing fertility preservations for patients with underlying medical diagnoses. I would say that it's been surprising for us on the obstetric front because COVID has not affected pregnant women the same way that H1N1 did, or the flu, or even the MERS and original SARS, meaning that pregnant women in those situations did pretty poorly, right? And frequently were admitted to the hospital and intubated. And for COVID-19, SARS-CoV-2, it has not been the same. And pregnant women in many ways have done better than their non-pregnant cohort, right? So what I say to women is that if you want to get pregnant, right? We do not believe that you're at increased risk, although the data is pretty limited because it hasn't been around that long. So as of now, it doesn't seem that it crosses the placenta and that it'll affect the fetus in a way such as Zika, right? But we are still letting women know that it's early. So do we know the full extent of it? Not yet. The only case where it could impact a woman's success, and this can be seen with any virus or any bacterial infection, is if you have an embryo transfer and then should get sick within the first 48 or 96 hours, that would likely impact implantation and you may not get pregnant. But that would be with any infection where you get a high fever, right? So we are sort of going along. Our fertility centers have changed significantly. Everyone is screened before they enter. We are now testing everyone before they start their fertility treatment to make sure that nobody has asymptomatic disease. But in terms of an ability to get pregnant, no real differences.
Right. So, for example, I'll just use my husband as an example. He's in an essential job, right? And so, he may be a carrier for COVID and not have symptoms or whatnot. And so what you're saying is there's no evidence that he would pass that along and that would affect the process or affect the fetus if it were.
At this point, no, it doesn't appear to, there's some illnesses or some viruses that cross the placenta, and we see very negative effects in the fetus, such as Zika, right? Zika caused a lot of problems, or toxoplasmosis or CMV,
right?
But that doesn't seem to be the case with Zika. Also, it's not, with COVID, it's not
COVID.
sexually transmitted in any way. So we don't quarantine gametes, eggs or sperm or embryos in the same way we would in a couple who was HIV positive, discordant, or hepatitis B, C, right? So it's different. Obviously, we're taking precautions for our staff and for patients, but less so because we think it's in the, the gametes or will be transferred between patients, and more so just for overall care.
Yeah, absolutely. Dr. Alexia, this question I've seen that actually came through a few times, and it might come through again today, is now that we're kind of, I hate to say the phrase sort of pulling out of this, and sort of people are kind of becoming more lax in certain cases and going outside, and some people are wearing masks, some people are not. I guess this is more of a general question that I think would sort of be relevant to anyone, not just in the breast cancer community right now, but this going forward in quote, newest normal, as we talk about, what, from a long game perspective, how can we continue to stay safe as these sort of restrictions start to lift? What are some of the biggest ways, because there's so much information out there, and some's great and some's not so great.
Yeah. So my take home would be keep the same energy, continue to be hyper vigilant about your own personal health and wellness and the folks that you live with. And if we all did that, we would all continue to show up at the grocery store with our mask on. We would all continue to practice hand hygiene. We would all be sensitive to the fact, no, you cannot sit in the waiting area of this doctor's office, this pre-op services. You can't be in the guest waiting area of the ambulatory surgical center or the hospital surgical center, because we can't risk for the health and well-being of your loved one who's on the exam table or the operating table, the doctors, the nurses, the scrub techs, everybody who's taking care of them, the administrative staff, all the way down to housekeeping. We really have to, for the foreseeable future, anticipate that we're going to have to get comfortable having surgical mask on and being unaccompanied in waiting areas and doing what we can to protect one another from this virus. We have to remember that still the vast majority of the population has not been infected and is still susceptible to this virus. And if we, just one day got up and all said, okay, we're not doing this, we can potentially find ourselves back in the situation where we're lacking personal protective equipment for all of us, as well as for the healthcare providers and teams who are taking care of people who are sick and potentially dying of this infection, that we could potentially crowd out our hospital rooms and operating rooms for the people who need surgery, whether it's emergent or quote unquote elective surgery. We have to make sure we keep ourselves safe so we don't find ourselves in the position that we were in previously. I know at our institution, patients were going everywhere you could accommodate a vent and a healthcare provider and team that could take care of them. That included our post-anesthesia care unit and some of our operating rooms. So we have to just do what is in the best interest of all of us so that we don't find ourselves there. We have to be patient and understand that, a vaccine is coming and many teams all over the world are working on that, but that's not a fast fix or solution, because it takes a long time to produce a vaccine that works and then to test its safety and then mass produce it so that everyone who can get it is able to get it and to know that it's safe and effective. So we literally just have to keep the same energy. Don't get tired.
That's great advice on many levels. Thank you so much. This can probably be a question for all of you in a different way, and this is something that I struggled with, virtual visits right now. Now, as we start to lift, I do have a follow-up scheduled in the office with my breast surgeon, but for a while, and so every office is sort of doing this differently right now. But how can we, because from a survivorship perspective, at any stage of the game, we all, I hope you guys know, we're all very codependent on you, and we really like seeing you in person, all of you. And so when we have the virtual visits or the televisits, it doesn't feel quite the same. We feel like, how can we be felt and prodded for lumps or blood work? You know, this is definitely very personal to me. Dr. Comen knows this, but I need to be in person. And so how do you recommend that we stay vigilant and safe when we can't see you? And this is really for all of you. Yes, Dr. Comen.
Can I go first? You can see I'm like burying my hand in my head, because I think from the other side of things, especially from the doctor side of thing, many of us are really struggling with telemedicine too. Like I'm doing the best that I can, but I know my best is not good enough. Like there's already pressure when you're in clinic and you feel like you've closed the door, and have you not, like, is there something left in that room that you didn't pick up on, or some sort of subtle cue that you missed? And now all of a sudden it's like with a camera, and you may be hiding in your closet from your kids, and then the platform shuts down and you can't reach your patient. And so there's like a lot of anxiety on the healthcare providers end too, that we recognize that and we miss it. Like, I love to hug my patients. I can't do that. And it feels weird. On the other hand, we have what we have, and we're trying to do the best that we can. So the good news is that a lot of us are seeing many more patients in person now. But with that in mind, for patients who are on active chemotherapy and whatnot, and then there may be other patients who are, you know, long-term survivors, we are trying to triage that and say, you know, for the next couple months, do we have to see all the well baby visits? And I recognize that for those patients who have done well for so long but still rely on the doctor, there's a lot of anxiety. Well, I still want to be seen too, right? So first of all, you guys know your bodies very, very well. And there's actually a lot that we can do on telemedicine if you see or feel something. Like I've been looking at women's bodies through the screen, I mean, all day long, where, you know, if you feel something, you can show it to us. We can then figure out, is it better for you to see the medical oncologist or the surgeon? You probably don't need to see both of us. So I think if you feel something and you're worried about something, will be seen. But in the absence of that, you know, it may be that your appointment is delayed a little bit longer than you would have otherwise wanted. And we get that. We feel that. There's a lot of anxiety in the air, and I wish I could like puff it all away, but I can't.
You just saved me a portal message to you. Why, thank you. Don't you love this? This is how I'm getting just free portal advice here. Dr. Peled, I'm sure you're getting a lot of questions as well.
Yeah, for sure. I mean, I agree. It's been really nice. We're starting to get to see more people in the office. I feel really safe about how we do social distancing. Everyone gets screened, gets a temp check when they come in. So I do feel good about if you have symptoms and you're feeling anything, I would rather see you too, you know? So I think this is not a time to be home with your breast symptoms. I tell my patients all the time, if you're worried about something, like don't be home worrying by yourself. Like call us, come in. And I feel that way now too. We can make things work. You know, if I have my patients who are getting chemotherapy, let's say, and they're worried about something, well, then we put them first thing in the morning or at the end of the day, and we really set it up so that there's no one else in the waiting room. So there are ways to do this that are safe. The thing for me that I've been really happy that switched over is doing screening imaging, but screening for follow-up for cancer. So we're still in a place, unfortunately, which is a whole nother topic, that we're not yet doing screening for people who haven't had cancer in the past or aren't high risk. But we just got back in the last couple of weeks to doing follow-up screening, imaging, both mammography, ultrasounds, and MRI. And I think that's a huge, huge thing for, you know, addressing some of the anxiety that people have. So for me, even if, let's say, I maybe am not going to see someone in person in my office, but I know that I can get them set up for their follow-up mammogram or MRI, it makes me and them feel so much better that at least they're getting followed and they're getting screened. So I think we're making really good progress on that side. And I would say, you know, we all have so much anxiety and fear and stress in general these days. And so I think going to get imaging, I mean, anxiety is very real. I'm due for my own MRI this month, definitely every day. I'm like, oh, maybe today I'll schedule, but no, not going to someday have to get around to it because it's really stressful, right? And I feel like I'm barely holding it together some days anyway to sort of add that on. It is a lot, and we all get that. But it's safe and it's open, and I think now is the time to at least be getting follow-up imaging, even if you can't get into the office necessarily for an exam.
Great. I'm sure Dr. Alexia and Dr. Knopman, you're hearing the same sort of things from your patients as well.
Mm-hmm. Yeah,
I would agree with Elizabeth. I cannot stand telemedicine. It's not my thing. I feel like we're used to being in contact with patients, and so much of, I mean, you get a lot of information from a history, right? Like a big part of how we know what's going on with someone, a couple or an individual in their fertility is talking, but it's also imaging and blood work. And I find it's definitely challenging, but I would agree with Elizabeth in that we are doing more in-person visits now, which has been helpful. What I've seen a lot of women or couples do is do an initial telehealth visit and then come in, you know, a week or 2 weeks later for the imaging and for the in-person part of it. But so that has changed it a bit. And I think we're slowly moving back to, as we're sort of talking about here, a new normal where we do see patients in person, but we're sitting in a consult, we're all wearing masks. Like that's totally different, right? When do we ever do that? So.
Right.
Yeah.
You were saying, Dr. Alexia.
Yeah, I think I've wanted telemedicine for years in my practice, and it basically our hands were forced. We had no choice but to have it, and I think it's here to stay. We didn't imagine ourselves when we first had a demand for telehealth doing initial consultations via telehealth, but sometimes I just need to chat about labs and go over how somebody's side effects are, and just say, okay, well, your liver's tolerating the medicine, etc. And I feel bad that someone has to take a whole day or a half day off from work. They have to sit in my office and wait an hour or an hour and a half when all I need to do is slide in and have 10 or 15 minutes FaceTime with them. It costs them so much more of their personal time to have that 15 minutes with me because the telehealth was not an option. So if this is the way we got it, then so be it. I think there's still room for it in our practices in the long run. It's not the ideal way to practice medicine, but there's a lot of visual physical exam that you can do. But I agree with what was said, like we lose that subtle body language. We don't see the wringing of the hands and the, crossing of the legs and that body language that says, well, what was that about? Or why did you respond that way when I asked that? Or I don't feel like you're telling me the full story. Like that opportunity is missed, but I think it also introduces an opportunity to really hear more from our patients because we don't have anything else. It is easy to want to rush someone through the history taking because you know what you're looking for on exam. You just want to know, are there lymph nodes swollen? Is there a palpable mass? Is this organ or that organ swollen or tender? Like we're already calculating that because we have no choice but to multitask. But without the ability to do that, then if you weren't already a good listener, which I like to think I am, you're even listening more keenly to what's being said because all you have is this history to make that decision. And so it really forces you to push even more for that conversation because you're going from history to differential to, okay, how am I going to navigate this workup? And, it requires a lot of knowledge on our part. I can't rely on my patient to know which outpatient radiology site is doing only COVID patients and which one is not, and you're not COVID, so please don't go there. I know it's closest to your home, but that's not the site for you. I do telehealth visits with my patients and I say, listen, I don't know what your lab is doing. I don't know how many people are coming in and out of there. I know in my office, we're disinfecting between every patient. I know that we're screening our staff when they come in every single day. And I know that we do not have, to the best of our knowledge, COVID positive patients coming into the office. So please come here and get your blood drawn and pick up your lab slips. And so we're just negotiating new territory, but it's going to be part of our new norm. The telehealth is not going to just disappear when COVID is, kind of more a part of our regular life. And it's been available, just not as widely as it was. So if it took
I saw NYU
for
been
it to
doing it a
happen,
while.
then, so be it. I think it's just another tool in our arsenal to take care of people.
Yeah, no, that's a great point. Thank you. So I want to get to some of the questions because I did get some texts with some great questions here. So this one here says, with respect to COVID risk, is an oral chemo, so this is probably for you, Dr. C, COVID risk, is an oral chemo, for example, Ibrance, considered an in-between as compared to ACT and hormone therapy only?
So it's a great question, and it's one that I think we're still evaluating and trying to get insight from a lot of patients in this regard. And so there's been a little bit of an art to the medicine of it to figure out what that really means and how we advise patients in the moment, because we don't have perfect knowledge, just like we don't have perfect knowledge about COVID. We do know that if you're getting ACT and you're right in the middle of chemotherapy, that is definitely different. With Ibrance, so just so we're all on the same page, Ibrance is a medicine that we use synergistically with hormone therapy, like like an aromatase inhibitor or like tamoxifen, and it's often used for women that have metastatic breast cancer. Now, for me personally, I will tell you that the practices have been different across the country. But for me personally, if somebody is on that medicine and they've been doing well and their neutrophil counts, for example, have been good and they're not dropping on the medicine, and we know that they've been on it for years, I haven't necessarily taken them off of it, particularly if these are people that we know are social distancing or isolating themselves at home. Now, other doctors may have different opinions, but it definitely is not like chemotherapy. We're monitoring those neutrophil counts, and I have not had any patients have any issues being on CD4, CD6 inhibitors like Ibrance, abemaciclib, Kisqali, ribociclib. They've been okay. But I just want to fully state that I do know that some doctors have taken patients off of it. The one caveat I will say is, in the middle of the surge, if I was starting somebody on hormonal therapy, I might not have started them on Ibrance if that was their very first time seeing the drug, because I wouldn't be able to monitor them as closely as I might otherwise have. But again, for patients that have been on it for 3 or 4 years, I was hard pressed to take them off of it when I knew it was really working.
Great. Okay, question 2 says, I am currently in treatment for metastatic breast cancer. How can I care for myself at the hospital as I go in for treatment each month?
So I just want to answer that one in the sense that I was just the inpatient attending, where I wasn't taking care of COVID patients, but these were sick breast cancer patients in the hospital, very sick. And I actually felt safer going to the hospital and going to my office than I do CVS or the grocery store. So we are, and I know that Dr. Alexia is too, we are so hyper vigilant now and so aware that we have to treat our cancer patients more than ever as the delicate flowers that they are. And I mean, we are just covered, we're disinfecting ourselves, everything's being disinfected. So even for patients with metastatic disease, you can show up for your cancer treatment. And certainly at Memorial, and I would think at other hospitals as well, as these other doctors spoke to, we're really working hard to keep our patients safe. And there have not been what we call nosocomial, meaning like hospital worker to patient transmission, and certainly as of late.
Yeah, I agree wholeheartedly. Even just a Zoladex injection at our cancer center, you can't just casually and haphazardly walk into our cancer center. You cannot just cross the threshold of the doors into the chemo suite. And even just going in to get an injection, it was a lot of steps that were in place in order to screen patients coming in and to prove that you got screened. When nobody assumed that just because you walked up the stairs to the treatment area that you definitely got screened downstairs. It was like, no, they had a measure in place to prove that you stopped at the desk, got your temperature taken, answered the questionnaire, don't have symptoms, and that you were wearing proper personal protective equipment. So if somehow somebody was distracted and I ran up the stairs past them, it still was like, wait, no, I know you just did that 12 and a half seconds ago down the stairs. You're still going to do it again up here, because we have patients, providers, and staff up here who we need to keep safe. And we're going to make sure that they're safe so that people can get the care that they need. I always remind people everything we do in medicine is held to a standard of care, and it's always risk versus benefit. And the benefit of what we do and how we do it always has to far outweigh the risk that's involved with it. And so I just want you all who are in our audience to be mindful of that. We don't make any of these decisions casually. There's whole teams of people working in the background trying to figure out how you can do things safely and effectively. So, just remind yourself of that. Like, everybody's doing the best that they can to keep everybody safe. Amen.
That's true. I have a question 3 here, and this is for everybody actually on here because there's going to be so much good discussion around this. But question 3 says, what are your thoughts on lowering the age of getting mammograms? And if it's normal, several years in a row, like a well woman exam that can go every other year. I'm sure we all have opinions on this. So whoever wants to start, because that's a big discussion.
Yeah, I mean, I think so. UCSF has a great trial right now. It's where I trained and still do research there. That's actually basically tailoring a woman's mammography screening plan to their overall assessment of risk. So it takes into account genetics, family history, prior biopsies, and they're really actually tailoring each person's screening plan. And as a trial, you actually can be randomized. So I think at this point, that just speaks to the fact that that strategy is still early on. But I have to say, I think that it's going to get adopted as we go forward, that we're going to be coming up with personalized screening plans, not just for our standard, high-risk screening we have right now, where if you meet a certain threshold, you're alternating mammograms and MRIs. I think we're going to actually see this across the board. And so we are going to get into a place, one of the arms at UCSF, you alternate you do skip that year. You do mammograms every 2 years. And so I think we're getting there. I think there's in general, and this is true for medicine overall, but certainly for breast cancer care, everyone worries about doing less. If we're going to go in one way or the other, we got to overtreat. We don't want to undertreat. We don't want to be missing things. And it's really hard to realize that, finding personalized medicine, you may be having people think you're undertreating, and that's got to be okay also when we do this. So I think we're getting there, but I think there's going to be a strong pushback on spreading out mammograms and doing less in the medical community.
Great. I'm sure you guys have anything else to add there? Opinions.
Well, I love that it is personalized, is the language that was used. Like, it's being done in a way that makes the most sense for that patient if it is going to happen. I'm not saying that mammograms are harmful, but again, risk versus benefits, right? And when you ask the question, my immediate thought about everybody getting a mammogram whenever they feel like it was kind of in the beginning of COVID, where there was this big question about masks. Should everybody be wearing a mask? And the initial pushback about the mask was that, well, you don't want people to not stay home because they think a mask is going to protect them. You don't want people to not wash their hands because they think a mask is going to protect them. You don't want people to gather in large crowds or groups because they think a mask is going to protect them. So the mask, just like the mammogram, makes sense in a certain context, and you have to be making an informed and an educated decision. I am one of those oddballs where if bad things can happen, they can happen. I was in the subset of women whose breast cancer was not picked up on a mammogram or a breast ultrasound. It was only picked up on a MRI. And it wasn't a small mass. It wasn't missed because of its size. It was 9 centimeters on pathology. So we have to be careful with that as well. So it has to be a tailored approach. It has to make sense for your risk. And that is a decision that really the experts have to make. It was the expertise of my breast surgeon that got me that MRI when the mammogram and ultrasound 2 weeks prior showed nothing.
Absolutely. Dr. Comen, Dr. Knopman, do you have anything to add? Or?
Yeah, I mean, I think you've heard from experts and wonderful insight into the complicated questions of how we address screening. I think right now, as an oncologist, I would still say, if you have a family history and you're backing up that screening, meaning before age 40, I still think that's a good idea. And things like MRI, if you have a greater than 20% lifetime increased risk of breast cancer, MRI is approved for screening. In terms of over the age of 40, I do think that for now, unless you're enrolled in a trial, and I know the trial to which she's referring, and I think it's an excellent trial, that, I err, because of what I do psychologically, forgetting the science, on doing it every year, because I think I see so many young women where the screening has helped. But I think the way forward and the path forward truly are these trials where we're seeing whether we can de-escalate, right? The Taylor RX trial, where we looked at chemotherapy for estrogen receptor positive breast cancer patients, was really important in de-escalating how much chemotherapy we give, women. Like 70% of women we're no longer giving chemotherapy to do in a certain category. And that's so important because we just heard today about how chemotherapy can affect people in the short run and potentially long run. You only want to give it when you need it. But when it comes to mammograms, MRIs, all of these, I think that right now they're the best at what we have. I'm involved in a study right now where we're doing a blood test at the same time where we do imaging to try to see if we can pick up microscopic cancer cells in the blood, so that when we do see something on imaging, we can determine whether we really need to biopsy it. Because one of the things that's really hard with mammograms is that they're not perfect, and sometimes women undergo unnecessary biopsies. And that can cause a lot of psychological harm, and people don't always want to come back after they've had a biopsy, and they're so scared waiting for those results. So if we can push the science forward with personalized imaging, figuring out who needs mammograms, who needs ultrasounds, who maybe can go 2 years, but also are there any other scientific techniques that we can use to refine and personalize the imaging, I desperately hope that's where we're going in the future.
Absolutely. I want to get to question 4 here. It says, could the panelists share perspectives on the utility of antibody tests? So I know this is a Dr. Alexia question, and I actually have that question too. Like, where are we at in terms of accuracy here? Should we be getting them? Does it make a difference? Thoughts?
So there are several antibody tests that are available on the market, and some of them have higher sensitivity and specificity than others. So is the antibody positive when the person truly had the infection? Is it negative when the patient truly did not have the infection? And there are clearly superior tests. So the other thing that I'll give you sort of anecdotally, what's been my experience, I've had many patients say, well, I had a really bad cold in December that isn't going away, and I've had the virus. And, several other stories like prolonged periods of breast illness and people who did not have COVID wanting an antibody test. They're widely available, as opposed to in the beginning when we did not have wide availability of the screening and diagnostic tests. So I don't have any hesitation about ordering the test, but I am keen on which platform that my patients got tested on when I give them those results. But for all of my patients who thought they had COVID when no one diagnosed them with it, I've not had back I had one single positive, and quite honestly, I thought the patient probably had COVID too, and she just wasn't worked up accordingly, and I'm still trying to sort out why. But otherwise, 99% of people who have just like, I think I had it, or if I had it and I have the antibodies, I want to volunteer for a study, none of those patients have tested positive. For my patients who have been hospitalized with COVID and are recurred, and I'm tested in follow-up, 100% of those patients have had positive antibodies. So we know that the tests work and that the test is sensitive and specific. I did have one person who had a definite documented asymptomatic infection and didn't seem to make antibodies in a time frame. So the tests have some validity, but you cannot get comfortable that so I won't get it again. Yeah, you can't rely on the test in that sense. And having an antibody test doesn't mean that you do or do not have COVID in that moment, right? So how do you know you're not an asymptomatic carrier just because you've made antibodies? People will have antibody production even when virus is still present. So that the antibody test is not used in the same way that the screening test or the diagnostic, which is one and the same, the PCR, is used in screening our asymptomatic patients who are coming in for surgery. I got a screening PCR because I'm having surgery on Monday morning to make sure I don't come in and infect my surgical team or any of the other patients in our surgical center. And I'm sending my patients who are symptomatic, not for antibody tests, for the PCR, the nasal swab. Is your respiratory symptoms or infection due to COVID, and do you have it right now? You know, so that's the distinction on those tools.
The problem we were seeing in our office, and you probably can speak to this, Dr. Alexia, are people who had COVID 6 weeks ago, right? Their symptoms, they're asymptomatic, and then they come to start an IVF cycle and they're still swabbing positive, but they also have antibodies. So the question is, we're assuming they don't have it anymore because they're asymptomatic and it was 6 weeks ago and they have antibodies. But I guess it's a virus, it's a PCR, so it's picking up dead virus at the same time. So I guess.
Yeah, that's a question that's, you know, not clearly answered or understood yet, right? Exactly. Are we picking up dead virus? And if so, why? Like, is the home environment contaminated and, you know, the person is touching their face or their nose and they're still, you know, infected or still potentially non-infectious virus particles around? Or is this person still shedding virus that is contagious to other people? And we don't know. We think that it's likely that they're not contagious, but we would never take the chance and tell that person, oh, you don't have to wear a mask because you had it, right? There's been few cases, but there have been documented cases of people being symptomatic, recovering, testing negative, having a symptom-free period, becoming symptomatic again, and testing positive by PCR. So we're still not clear if the vast majority of people who get this infection are going to be able to get it again, like a flu. So we still have to maintain the precautions. So masks and distancing are just going to be with us for a while. So again, the new normal.
That's the takeaway from Dr. Alexia.
We can't emphasize it enough.
You're like, if you've learned nothing today, please continue to wear your masks and social
Please and thank you.
Please and thank you, yes. So we have 1 minute left. And so I just wanted to take a moment in case we get cut off to thank you all for joining and your areas of expertise and your wisdom. You know, I know I follow some of you on Instagram, but I will be following everybody, you know, just to continue to have this network, and your participation here has been excellent. So thank you. Any last words for people out there to kind of stay mentally healthy and safe right now? And if we get cut off, we get cut off, but go.
I'm worried about the mental health part. I feel like women who are diagnosed with breast cancer in the middle of a fucking pandemic, okay, like a fucking pandemic. Can we say that? How many times can we say that?
Say it loud for people in the back.
Right? I mean, I think it's amazing that you guys are putting this together. And I'm sure it's not the same thing as being together, but thank God you are doing it. And to everybody who's out there who's trying to virtually connect, like, you are definitely not alone. You have this amazing tribe to rally behind you and keep you together. But there's so many resources out there. There are a lot of therapists that are working, you know, telemedicine. It's not perfect, but it's something. And I just want to give everybody a big virtual hug. The doctors and the patients, it's just a shit show, but we're doing the best we can, and you're not alone.
Absolutely.
Thanks, Dr. Comen.
Yes.
We know how important support is when you're facing a cancer diagnosis. We know statistically people who are well supported do better. And so when rounding on, you know, all of these patients in the ICU who are alone, my mind as a physician immediately was like, how many people aren't surviving because they don't have a family member holding their hand, whispering in their ears, saying prayers in their ears, telling them they love them and they want them to pull through and recover. So I have it that the lack of support has an impact in this pandemic for those who are sick, and certainly as well for those who aren't sick. You know, we're communal beings. We're used to being together. We come together in celebration. We come together in mourning. You know, how many of us have rallied our girls and our guys because we were going through something and we just needed to be present with one another. And so thank God that we get to experience a freaking pandemic in the social media era. How would we have survived the 1918 flu, where people were isolated, socially distanced, and just hearing the bad news and not able to see and connect with other people? So we are incredibly lucky that we have these platforms and this technology to get together and to not lose or miss out on Camp Breastie, but to just move it somewhere else and make it happen for all of the women that need this community and need this support. How lucky are we that it's virtual, that we can have all these medical experts? You know, what are the odds that every one of us would have been able to take off from work and go to Camp Breastie if it happened in real life? Because that's what I was faced with. So the ability to just pivot and make it happen for all of us is amazing. And so thank you for that.
Oh, thank you.
Yeah, I was just going to add, I mean, I think all of us know, right, that cancer diagnosis, finding out your genetic carrier, these are such incredibly disruptive events, right? And for anyone in any time, I mean, it's incredible, right? It throws your entire life off in this dramatic way. And we're dealing with that in the setting of a pandemic that has also exploded everyone's world. And I just want everyone to know, like, we get that. We are here, we're understanding. You know, my patients will send me these cute emails like, I'm sorry, I'm so high maintenance. I'm like, you are not high maintenance at all, right? You are trying to take something that is just completely throwing your life, this huge curveball in the midst of an already completely stressful situation. And we understand, we get that. And so again, I just think, you know, find the things that you need. Don't be afraid to express. You know, you want to move your surgery date, you want to have this part, like, don't be afraid to ask those things, because we get it. We all get it. And we're all trying to do the best we can to give everyone some semblance of control and decision-making and choices in the midst of a totally out of control mess. So we're here for you.
Love that. Love that. Well, thank you again, ladies. It was such a pleasure, and I'm sorry I went a few minutes over, but I think that was worth it. Thank you for your support, and I'll find you on the socials.
Thanks,
Bye,
Tiffany.
everyone. Thank you.
Thank you so much.
Bye.